Rural general practice is often seen as a front line of medicine where broad skills, strong relationships and clinical independence come together in some of the most rewarding yet challenging environments. But what does a career in rural GP really look like? Where can it take you? In this episode of Aussie Med Ed, we're exploring the journey from rural general practice to specialist roles with a spotlight on how working in the country can lay a powerful foundation for diverse career paths. Joining us today is Dr Chong Han Lim, known as Han to his friends. He began as a rural GP in Tumby Bay in South Australia and is now a dual-trained pain and palliative medicine physician. We'll unpack his unique story, the skills rural practice can develop, and what opportunities exist beyond the bush for those starting their careers in rural medicine. In this episode, we'll explore Han's journey, the challenges of rural medicine, and the lessons he's learned along the way. Welcome to Aussie Med Ed. Good day and welcome to Aussie Med Ed, the Australian medical education podcast, designed with a pragmatic approach to medical conditions by interviewing specialists in the medical field. I'm Gavin Nimon, an orthopaedic surgeon based in Adelaide, and I'm broadcasting from Ghana land. I'd like to remind you that this podcast is available on all podcast players and is also available as a video version on YouTube. I'd also like to remind you that if you enjoy this podcast, please subscribe or leave a review or give us a thumbs up, as I really appreciate the support and it helps the channel grow. I'd like to start the podcast by acknowledging the traditional owners of the land on which this podcast is produced, the Kaurna people, and pay my respects to the elders both past, present and emerging. I'd like to remind you that all the information presented today is just one opinion and there are numerous ways of treating all medical conditions. It's just general advice and may vary depending upon the region in which you are practicing or being treated. The information may not be appropriate for your situation or health condition, and you should always seek the advice from your health professionals in the area in which you live. Also, if you have any concerns about the information raised today, please speak to your GP or seek assistance from health organisations such as Lifeline in Australia. But it's my pleasure now to introduce Dr Chong Han Lim. Han to Aussie Med Ed. Originally from Singapore, he obtained his medical degree from Adelaide University Medical School, initially working as a rural GP in Tumby Bay in South Australia before becoming a dual-qualified pain and palliative medicine physician. Outside of medicine, he's also the chef and owner of Katong House, a Singaporean restaurant in Adelaide. Han, thank you very much for coming on Aussie Med. It's great to have you here.
Thank you for the invitation.
It's brilliant to have you along. Perhaps you can first of all start us off by walking us through your medical journey from training as a rural GP in Tumby Bay and to your current roles in Adelaide as a pain and palliative physician.
Yep. So, my journey is a bit convoluted. It's a bit strange, not your typical journey. So, came from Singapore originally and went through, Adelaide University Medical School, graduated in 2009, started internship in 2010 at Lau Mercury Hospital. Initially, I wanted to be a surgeon. So, I actually did the Master's in Surgical Science and realized that I'm not really cut out to be a surgeon because I have too much interest in life. And by a stroke of luck, I was the intern for palliative care, and subsequently I got another stint as an RMO in palliative care up at Lau Mercury. And that was when I was really interested in palliative care and thought really seriously about doing palliative care. Now, to get into palliative care, there's two streams. So you can either do med-reg, basic physician training and get into palliative care training, or you can go through other colleges. So fellows from other colleges can also attend the advanced training in palliative care. So I started as a medical registrar, and it was quite difficult because back then, straight off internship, I was thrust into like a registrar role, doing night registrar. 15 years ago, it's a bit different from now. So it was quite daunting. And I thought that if I just wanted to do palliative care in future, I could just, do it through the GP pathway. So I signed up to do the GP fellowship without actually really knowing if I would enjoy it. I thought it would be interesting to find out a bit more. So I wanted to go somewhere really rural. Because I was from Singapore, Adelaide at that point in time was a rural country town to me. And I thought that I needed to immerse myself in this, so I should go somewhere really rural and then somehow end up in Tumby Bay. So I went to Tumby Bay for an interview, and Karen Speed was the manager at that point in time of the practice. sold the practice to me by saying that, we have our GPs over here, Dr. Dennis Eaton, Dr. Graham Fleming, and Dr. Judith Dagner. In combination, they have over 100 years of medical experience for you to learn from. So I thought, oh, that's good. So I basically signed up for 6-month stint just to see how it is, whether I really enjoy it and stuff. And ended up finishing my entire training in rural medicine over there and staying on for 6 years. So that was how I got into rural medicine and again practicing as a rural GP in Tumby Bay.
Right.
Yeah.
Well, it's amazing. Just to put it into perspective, how far away is Tumby Bay from Adelaide?
It's about 750 kilometers away.
So it's a decent distance.
It is. It is a distance, like driving.
And for those listening from overseas, Adelaide is the next major hospital scenario, really.
The tertiary hospital, yeah.
Who would you refer to? Is there any backups from Tumby Bay?
So Port Lincoln would be our secondary referral centre from the Tumby Bay Hospital. And there is, it's staffed by a general physician, Dr. Rufus McLeay, and a general surgeon, Dr. Quinton Ralph. And basically they do, like us, being rural practitioners, they do everything.
Right.
Yeah, and it's quite interesting.
And how far away was Port Lincoln from Tumby Bay?
It's about 50 kilometres, half an hour away.
Yeah.
Yeah, on the highway. Yeah. So it's not exactly near, but to the country people, that's quite near.
And the population of Tumby Bay?
So our coverage is about 1,500 to 2,000 people around the region, because we don't just cover the town in itself, because in the surrounding region there's farmlands and unfortunately some of the other towns have no doctors, so we tend to have a bit of spillover from the other surrounding areas. Into town.
Excellent.
Yeah.
Right. So in that area of 2,500 people, what sort of distance would they be covering? That'd be a fair few Ks, I would imagine.
Yeah, well, it depends on how far you want to drive.
I'd like to let you know that Aussie MedEd is supported by HealthShare. HealthShare is a digital health company that provides solutions for patients, GPs and specialists across Australia. Two of HealthShare products are Better Consult, a pre-consultation questionnaire that allows GPs to know a patient's agenda before the consult begins, as well as HealthShare's Specialist Referrals Directory, a specialist and allied health directory helping GPs find the right specialist. So it really is quite rural.
It is.
And what lessons did you learn from being a rural GP?
I learned to actually be, I think, in a way, a better doctor. Not so much based on technology, based on back to basic clinical skills. Do you remember the first week I was there? Dr. Eaton brought, an arrhythmia, an ECG with an arrhythmia for me to have a look. And it's like, what would you do? And, it just came from the city. I would say, all right, we need a cardiologist, we need this, we need that, we need CCU, we need monitoring continuous. Came out with all the standard hospital answers. And Dennis just went and said, well, the nearest cardiologist is 750 kilometers away. So you're it. And he just went, panic slowly, my son, panic slowly. And then, that was how I was taught. So I was their very first registrar in 100 years. They never had registrars before. And so when I was there that year, they just celebrated the 100th year anniversary of the local hospital. So that was my introduction to rural medicine. I then realized that, you can call for help. But really, in reality, the nearest tertiary hospital is over 700 kilometers away. And you really have to be dependent on a lot of things, what you have and, what you can do with the resources that you have, and basically diagnose patient based on real clinical skills. The nearest MRI scan at that point in time was in Wa'ala, about 350 kilometers away. Yeah. So it's not near.
Right. So really, you would have learned resilience from being in that sort of scenario. Having worked now in the city practice, perhaps we'll draw on that in the future, but what other things do you notice as a difference? And what would you say are the main benefits for a young medical student coming through the programs?
Okay, so I guess the main difference would be you are actually part of a community. So you see the patient, you interact with the patient both professionally, socially. You go to the pub, you see them at the pub. There's always what I call supermarket consults. Like you go to the supermarket and you're like, oh, Dr. Lim, the results, how's that going? And sometimes you just don't want to, you don't want to talk about it in public because it's just not professional. But you are part of the community nonetheless. And certainly when you need to intervene in something, for example, if you need to arrange for, let's say, a site visit to see how you can, modify some of the jobs for patients, that is much easier because, within town itself, it's quite easy to get to. And it's a phone call away, you know them, you can arrange something. Whereas over in town, in Adelaide or in the city environment, then you have to organize it through maybe a third party. It's much more difficult to get there, even though it's much bigger, but there's more bureaucracy to get through. So in a certain way, it provides better holistic services in whatever limitations we have. Obviously, there are limitations like allied health is quite limited in the country, as you can imagine. Whereas over here, if you talk about physiotherapy, there's many clinics around Glenelg area, but in town, we have a visiting physiotherapist. And then now, currently, we are lucky enough in Tumby, one of our GPs over there, the wife is actually a physiotherapist too.
Right.
Yeah, but it's just limited in resources.
Right. And well, there is difference in presentations too that you might see in the country.
Yeah, plenty. So over here, you see like your chronic diseases management, you see like your sick clinic acute presentation. But over there, you could be doing a flu vaccination and getting a call from the hospital with someone having a MI and then rushing to the ED to manage that. We have had many instances that has happened, and we are quite lucky in Tumby Bay. Most country towns have problems retaining doctors. Some country towns don't even have a doctor. Whereas in Tumby Bay, we are quite lucky that we have, Dr. Eaton, Dr. Fleming, who's been around for 40 over years, providing continuity. And we also have like newer doctors like us who stay around. So after me, the Dr. George, Sarah George is a registrar after me, and Dr. Emmy Hanno, who is actually, her story is quite special. We might touch a bit on her because she was a graduate from here, did internship, and became a teacher's wife for the next 20 years.
Right.
And then finally went back into medicine after her children went into school. Her youngest, she had 8 kids.
Really?
And yeah. So when the youngest went to school, she started at Waiala Hospital as an intern and then went through the training fellowship. So then obviously they all stayed on. So there were quite a few of us, 5 of us actually.
Yeah.
And when something major happened, it's very collegial. So we all help each other. And in that way, we have the support. So in a way, Tumby Bay was very lucky. We were very lucky that there was enough doctors and we were very supportive of each other. Whereas sometimes I find in urban practice, it can be more isolating. Like you would think that in country practice it's isolating, but in our situation, we were lucky. If let's say you're a single GP, for example, 24/7
Right.
on call,
Yeah.
and so that could be certainly very difficult. But I guess we were lucky in a way in Tumby Bay.
So I presume it's not just about the types of medicine you give to, it's also about the community you're in. I presume it's like that every day of the week in working in a country practice, is it?
Yeah, it is. So again, because of our unique situation, our we had wind downs. So almost every day we had what we call wind down with the doctors, the nurses of the practice, and the receptionist. It's a good way to debrief about the day if there's any problems or any difficult, challenging patient. You sought advice from everyone, and it's not just a person, one new single person. So then in the morning, the doctors start doing ward rounds together in the hospital. So we know all the patients that are inpatient at present. And subsequently, if you're on call, you can deal with anything that comes your way because you have been briefed. So it's rewarding in that situation. And then after that, the pub. And so in a way, it's a simpler way of life. Whereas over here, if you want to meet up with friends, you have to make an appointment. Whereas over there, most of the time you call up and say, oh, you want to go dinner tonight? Oh, sure. Yeah. And there's not much choice. There's only 2 pubs. So you don't really have to rack your brains about, where to go or make a booking somewhere way in advance. And in a way, it's a simpler life. It's actually, I actually appreciate that quite a lot.
Excellent. So obviously, as you put down as one of your hobbies as being a foodie, yes. And you're now a chef of your own restaurant. Does working in a country town actually help you develop your cooking skills and your abilities that way? Or was that something that you had before all that?
Well, I converted. So I have a property over in Tumby Bay, and I converted a shed into a dining hall.
Right. Okay.
Because I love cooking and I love having friends over. So my friends will come over often, for barbecue, or I'll cook something. And the practice, the doctors, the nurses will all get invited. I think we do that quite frequently. And it helps with, in a way, it did help my cooking skills a lot. And apart from that, most of our nurses, our practice manager after that, Michelle, she's a great cook. So, you learn tips, she comes across and then she helps out. And so it did help me. And obviously because I'm from Singapore and I want to show them what Singaporean food is. And so I cook a lot of my own food to let them try, like curries and rendang and stuff like that. Because there isn't much exposure to Asian food in Tumby Bay. In fact, there's no Asian restaurant in Tumby Bay. Right. I think that's my house. So it did help hone my skills in cooking and my passion in cooking. And that's why when I came back here in 2021, I thought that I'll just take the leap and start my own restaurant.
Brilliant. Obviously, COVID sort of taught us all that there's more to life than just working. And whilst us as doctors, we all like to work and like the reward of helping patients. It sounds like Tumby Bay and a rural life, it actually brings out in a lifestyle. Would you agree with that?
Yeah, absolutely. It's work is important, obviously, and you are there to provide a service to the community. However, at the same time, people want you to be involved in the community too. So I remember when I first went there, people start knowing you and then you get invited to go on fishing trips. I don't fish, but I get seasick. So I have to politely decline. But, people will be asking you to, come along, we'll bring you out, we'll bring you exploring. And there's all these activities that people try to make you feel welcome. At the same time, you make your own friends. So I was very lucky to have my group of friends over there that there is a local group called YTAP, which is Young Trades and Professional Association, which I initially joined and got to know a close group of friends over there. And so and that helped too, because I can imagine if you by yourself move to a place and no friends, so you might actually feel quite isolated, and that's actually quite stressful. But I was lucky that I made friends who are of similar age group and similar interests, and we still remain great friends now.
Brilliant. That a large percentage of South Australia is not even covered by councils, and that most of the services are provided by everyone mucking in and helping each other out.
Yeah. That is actually very true. That's very how the country people think. They actually help each other out a lot. One example, and that really touched me at that point in time, not sure if you remember, but a couple of years ago, we had this massive blackout throughout the state. And we were without power in Tumby Bay for a couple of days. Things didn't work. Mobile, there was no reception. We couldn't charge. We had a generator in hospital. So when there is an emergency, what would happen? We then had a contingency plan with everyone in town. So then the hospital will have to call the police on the walkie-talkie, and then he'll come and knock on the door of the doctor on call to alert him to the need to get to hospital. And there was no lights, so most garages wouldn't work. So then we might have to go in a police car. But the problem was the hospital generator runs on diesel. And I remember we were running very low on diesel, and to the state that if we don't get power back that day, we will most likely be out. And without asking anyone, we had volunteers like the farmers, because they have their own silos, and they actually called the hospital and said, "Do you need diesel? Because if you need any, we're ready to come in and fill up the hospital, because it's needed at the hospital for the inpatients and stuff." And I found that really touching. I'm not sure. I'm sure if something like that happened in Adelaide, there will be people who would do that. But these are, the farmers, the local resident of Tumby Bay, planning ahead and looking after each other without no one asking. And the pub was providing free meals because the fridge was out, so they had to clear stuff. And there were people who, with generators at home, they were opening their house out for hot showers for people and all. And it created a community of help within the community. And I don't remember anyone asking for it. They just opened up.
It's amazing.
It is. I think the country spirit is really alive in the country, which unfortunately sometimes I don't see that much in urban areas. Yeah. But in the country town, it's just that.
It's brilliant.
Yeah.
What happens in an emergency? You're looking after a patient and you really are struggling. You've done all the right things. So you've got someone who may have an acute appendicitis, and you're concerned that it's actually more complicated, or a severe heart attack that needs to be transferred into town in Adelaide. Yeah. What actually happens in that scenario?
For acute appendicitis, it's simple. We just call Quinton Ralph and tell him that we're sending a patient down, and then we manage that locally, and so that's simple. But for things like a MI, a heart attack, or something a bit more requiring retrieval to the tertiary hospital, then we can always call for cardiac stuff ICARNet. Otherwise, you can always call the retrieval services, which is Royal Doctors Flying Services, and communicate with the on-call hospital and the specialist who's on call, like the ED specialist or the ICU specialist that's on call, and get help in that situation. In saying that, there are many, many interesting experiences that I had, which would be quite amusing to listeners, and showing how sometimes it's quite difficult to transfer patient. For example, one patient had a metastatic cancer, caudate equina syndrome, and I called up requesting to transfer. So I actually, at that point in time, we had to get the approval from a receiving specialist in Adelaide, so called Royal Adelaide, called neurosurgery. Unfortunately, registrar wasn't there. It was an RMO that answered, who was taking calls. And I explained the situation to the RMO, and the RMO was like, "Yeah, how do you know it's caudate equina syndrome? Have you done an MRI scan? Why can you?" I'm like, "Well, I stuck my finger in." and they can be quite obstructive at times, and so very often when we go nowhere with the junior doctors, we then call the consultants straight, which are usually much more accepting, and they understand the situation we are in. It's a bit unreasonable to ask about MRI scan when your nearest MRI machine is 350 kilometers away. And so I think everyone, from medical students or even people who are training, in their various specialties should spend some time in the country.
Yeah, yeah.
But other challenges like getting crash blood. So the blood bank is in Port Lincoln Hospital that is 50 kilometers away. And I still remember we had a time with a patient came in with hematemesis, and we had very basic like hematocrit and blood tests, point of care testing. And there was a big dramatic drop. His hemoglobin was like 80s, and he was hypotensive. And then I had to get blood. So called Dr. Fleming. He rushed down to grab crash blood and raced up. And he was on the highway and he was going quite fast. He got stopped by the police, who obviously knew him. And the police knew of the situation, and the police grabbed the blood and raced back to Tumby. And that's, again, showing how, it's not, if you need crash blood over here in the tertiary hospital, you write a request form and the orderly would send it here. Yeah. But over there, we had to get a police escort, and it's half an hour away. So you have to manage the patient and stop the patient from literally bleeding out and dying within that time while you wait for the crash blood to come. Mm. So it has its challenges. I think with technology has improved because you're able to get help. And now so back then we didn't have the video consult, but now there is a video consult available, so the ED consultants can actually see what's happening in your ED and give advice based on what they can see.
Is that something that's happened since COVID started?
Just before COVID, COVID really kicked it off.
Right. On that basis, what is the access to specialists like in that area? Is it do they come up and visit?
They do. So they do come out and visit, but obviously it's not not as often as we would like. And because when they do come and visit, they cover a wide area, and not just in Tumby, they are other towns. So they usually stay in Port Lincoln, who is bigger, and get the patient's referral from all over the region. But like I said, we were lucky with the general surgeon and the general physicians. They do everything. Like Quinton would whip out an appendix, or he would, do something like a colonoscopy, and Dr. McLean might then, do a scope too and read an ECG at the same time.
One of the other things I would notice that might be different perhaps in the rural areas, that, as I understand, a lot of the GPs do a lot of procedurals like removal of lumps and bumps and other things. Yeah. Did you have any experience with that when you were there, Han?
Oh, plenty. So, again, I was very lucky to be taught by, experienced GP, and there were things that I have never even thought about doing in medical school. So, for example, we had a lot of builders and a lot of, laborers who were using grinding machines and all that stuff. And they have eye injury from not wearing proper safety glasses. Yeah. And so you just have to blur out the rust from their corneas. So basically you anesthetize the eye, putting in a local anesthetic. Really? Yeah, and then just blur it out, or take out the stones or splints or whatever they have in their eyes and remove that. So that's just one of the minor procedures we do, which I don't think a lot of urban GPs would actually do. They'll send them straight to the ophthalmologist. And we have other, like in emergency situation, we will put in things like chest tubes, or in palliative care too. Sometimes we just have to be a bit more creative and do, like, for example, if let's say I have a patient with ascites, then I have to do a ascitic tap and I have done many ascitic tap with just a large bore IV cannula, and then connecting it to a IV giving set and reversing it into a bucket.
Oh, really?
Yeah, because we don't actually have the whole setup, but it's not something that it's difficult. It just needs a bit of creativity, as long as it's not causing harm to the patient and it's safe. We tend to do it more just because we don't have the facility to have all that, and we are not going to send a patient 700 kilometers just to get a ascitic tap done. Yeah, so it's something that you just have to learn, and I was very lucky that I had good experienced GPs to teach me that.
What about orthopedics? Did you get any fractures to treat?
Now, this is a story you enjoy. So this is an even older generation. So Graham and Dennis told me this story. When they were registrars, so that was a good 40 over years ago, there was a rural general practitioner, a rural doctor, that because that was before the age of X-ray. So if a patient comes in with a fracture, he would get the matron to drop ether, that's how old it is, ether to put the patient under. And then he would scrub in, open up, look at the fracture, because there was no X-ray. So he had a physical look at the fracture, scrub out, go into his workshop, fashion out a plate, and then sterilize that while the patient's still under, come back and fix everything in.
But I take it's not like that now.
No. But that story is stuck, how resilient country GP, and that's how rural GP, rural medicine evolved. But in our situation, like if we have a fracture and stuff, we had to do our own X-ray.
Yep.
So we have our own X-ray machine, and I used to have, I've given that up now, unfortunately, but I used to have a X-ray license. And we had to do an X-ray, and before that we even had to develop our own film in a red room and have a look. But now we have the modern reusable plates, and everything is quite automated. So we had to read our own X-rays back then, and if there was a fracture, then we have to call for retrieval. So they are usually sent across to the fracture clinic in town. Just like plastics and all that stuff. Depending on whether it's an urgent thing or whether if it's stabilized, then we can wait for transport, or they can even go on a commercial flight, for example, if it's all neurovascularly intact. But if it's an emergency and stuff, then they get retrieved over.
Your back slab skills would have come in handy though.
Oh, you think of everything like back slab, you think of ways to make the back slab from cardboard, from whatever you can find.
Excellent. Is there anything else you'd like to add to that for the listener at all?
I think there is a common misconception that rural GPs could be a bit of a cowboy and a bit like very gung ho to deal with stuff. But I don't perceive it that way. So you don't?
No, I take my hat off to you. It's brilliant. So
I think we should talk a bit about rural training. Yeah. So it's a bit distinct from urban GP training. So usually it's additional training. So we have two colleges in Australia. One is the Royal Australasian College of General Practitioner, and then one is ACREM, which is the Australian College of Rural and Remote Medicine. So the time is quite different from being a rural generalist. So that's the term now that we use. In the past it's rural GP, but now the term is rural generalist. So a general practice or a GP training is 3 years in general, while rural general practice is an additional year, so it's 4 years, an additional year of training in an area that might interest you. For example, there are GP obstetrician or GP anesthetist, so then they have to do like a diploma in obstetric or diploma in anesthetic to be able to do that. So in a lot of areas, so you do have to do additional training to be a rural generalist. There are also rural generalist surgeons who their training is slightly longer. So rather than being just one additional year, they might have, I think there are additional 2 or 3 years. And they could then do things like simple appendicitis and appendectomy and stuff like that. So it is a rewarding career, but it has additional training to be a rural generalist, additional requirement to be a rural generalist. So we do have that extra training and not just all gung ho and and do it. So in Australia, that's what you need to be a rural generalist. So for those overseas listening, it's who want to have an experience, maybe you could come in and have an experience in the country yourself. Go and experience that.
Yeah.
Provided you could get
At least come and observe anyway.
Yeah,
Do a
exactly.
visitation.
Yeah.
Obviously, you went there with the idea of moving towards palliative medicine as well.
Yes.
Did you get any experience with the palliative medicine in the rural setting?
Yeah. So we were lucky. We had a visiting palliative care specialist, so Dr. Roger Hunt, who sort of dragged me into palliative care training, and he's my mentor in palliative care. And so back then, a lot of those skills, like I told you about acetic tap, I learned from him too. And because of the procedural skills we had as rural general practitioners, we did nerve blocks over there. For example, if let's say a patient had a sarcoma in the leg, we did a femoral block because the patient wasn't mobilizing anyway, and rather than just a single block, we would connect that to a continuous pump, and that's what we did. So we basically blocked it with, again, an IV cannula and just left it in as the end-of-life care, and then manage pain in that way. So again, creativity with what we have in the country. And a lot of times patients actually prefer not to be transferred, obviously, because their family is over there, support system is over there. The community support is very strong. And we are lucky that we can actually manage to move patients we have a little palliative care ward set up in the hospital. So from the community, from home, if they need to be admitted, we have the ability to admit them into hospital, and yet they're close to their family. So there's a little family room in there, and the family could be there. So it's really quite a nice setup from a palliative care point of view. But the whole Tumby Bay Hospital is amazing. Every single room faces the sea.
Oh, really? Oh, that sounds
Great view.
Great view.
Great view.
Yeah, I teach the medical students that palliative medicine, I think orthopaedics has got a reputation of being the tough buggers around the place because we fix broken bones, but really I think palliative is really, you're very strong to be able to do that. And the orthopaedics, we're soft, and I think it's brilliant that you've got that. We interviewed Professor Greg Crawford about it.
Yeah.
He talked about the importance of a rural palliative medicine approach as well.
Yeah, he was from Kangaroo Island.
Yes. So he said that really helped as well. So I think it's a great approach to it.
Right. It's actually so Professor Crawford was the one that actually taught me this, that you can always try things as long as it's safe for the patient, because then as long as you're not causing harm.
Yeah.
Because if that's what you have, that's what you have. You can't have anything more than that. So that's just what you have and what you have to think about. But as long as it's not causing harm to the patient, that's fine. We can always try.
I'd like to let you know that Aussie MedEd is sponsored by Avant, Medical Legal Indemnity Insurance. They tell me they offer holistic support to help the doctor practice safely and believe they have extensive cover that's continually evolving to meet your needs in the ever-changing regulatory environment. They have a specialist medical indemnity team located here in Australia and have access to medical legal experts 24/7 in emergencies.
Brilliant. So it sounds like you've maintained a connection with Tumby Bay. You've still got a property there, have you?
Yeah.
But you had to move to Adelaide for training as a palliative physician?
I did. So in 2018, I, with the support of Dr. Hunt, came back here to do my started my advanced training in palliative care, because, that was part of what I was thinking. I was always interested in palliative care, but then I thought being a rural GP, I was quite happy with that. But somehow fate intervened, and I came back and started training in 2018.
Right.
Yeah. And then halfway through that, I realized I don't actually know a lot about pain, because we give opioids, but there are more than opioids to deal with pain. So then I did a stint in pain medicine for 6 months as an elective, and then decided to go ahead and do the full training, and did both training at the same time.
It's brilliant. As well as being a chef, as well as maintaining a connection with Tumby Bay.
Yeah.
So you've
kept busy.
You've kept busy. You've got three homes, I take it. You've got Adelaide, Tumby Bay, and I presume Singapore is still a connection.
Yeah.
So
yeah.
Ironically, I presume the distance between one side of Singapore to the other is probably smaller than 700 kilometres, I presume,
Oh,
from Tumby to...
Singapore is 6 times smaller than Kangaroo Island. There you go.
Yeah, and so your friends at home in Singapore too would find it interesting. Your next closest tertiary centre was 700 kilometres from Tumby.
Yeah. They so my friends in Singapore who are doctors who can appreciate that they're always amazed by some of the stories or some of the challenges that we face, and the chance that you can actually experience that is quite rare in Singapore, because nowhere is rural in Singapore, as you can appreciate that.
Right. How do you feel about palliative medicine and pain work now? Is it it's a different side of life? I would assume those two areas are also a close community in looking after not just the patient but the relatives of people going through palliative care and those requiring pain relief as well. It's probably as similar in some ways as a local community in Tumby Bay in that way, is it?
From my observation, I think in the country, even though they are limited, like I said, the community spirit is strong. So in a way, there is more support, whereas being in the urban centers, even though the population is bigger, but sometimes the isolation from the community is actually greater. We see a lot of patients in Adelaide who are not able to have end-of-life care at home, because it's very involved. If you think about end-of-life care at home, it's actually very involved. You need the equipment, you need the nursing specialty, you need they can't be there all the time, so they can come and draw out medications for you and help with certain basic nursing care, and then you need a lot of family support. You need the family to be there to support the patient, to provide PRN medication, for example, to move them, for example. And it's actually quite taxing. Whereas in the country, the community can come around and do that. Especially if, let's say, the family is a bit stressed, or the family needs to go and work on the farm, for example, the neighbors might come in and step in and help look out during that period. Whereas that in urban areas, I find it's sometimes lacking. So even though the population is bigger, but the isolation might be greater.
Very interesting.
Yeah, that's my observation.
It's sad, isn't it?
It is. So unfortunately, in palliative care, especially in end-of-life care, as you can understand, the public system is quite stretched. The amount of need in the community and what they're funded to do, and the number of doctors and nurses and allied health expertise that's available for the community palliative care team is quite limited. So that has its own challenges. Whereas in the country, you have the rural GP doing everything, coordinating stuff with the help of the family, even though you might think that the resources are also very limited, but you drop in for a cup of tea and and have a look at and chat with the patient, and that to them is calming. It's kind of support. So in a way, I think in the country, in a smaller community, that might be sometimes easier.
Right.
Yeah. It's strange, I know, but that's my observation.
Right. So in some ways, it's more challenging in Adelaide than
it is.
Yeah.
It is. And also, I think the country people are more resilient. They acknowledge and understand that there is a limitation to resources, and they make do with it. Whereas there's a certain expectation that this is not good enough. We need this. We should be able to assess that because it's convenient. It has always been convenient for them to assess services, and the expectation is different. So I think the difference in expectation actually makes a difference.
Right.
And obviously the resilience in it too. Yeah.
Where do you think palliative medicine is going, both in the country and in Adelaide?
So in the country, the palliative care services are run mostly by nurses. So with the support from palliative care consultants or palliative care specialists in the 3 services, Naarlen, Cullen, and Salen. So that's the local health network we have in Adelaide. And they provide specialist input if needed. But by and large, it's mostly run by the nurses. Now, there are very limited nurses that do that. And the distances that they have to cover are quite great. So to see a patient, they might drive 200 kilometers just to see a patient.
Jeez.
Yeah, so that kind of help or that kind of service is obviously daunting and difficult to maintain in the long run. So shout out to all the palliative care nurses and nurses of the country and all the rural doctors. They are actually quite amazing because of the areas that they have to cover. I think in future, if we are able to get more like telehealth and with technology, that would be good. Currently, you need the nurses to go there because some of the older patients might not be able to handle technology and also internet connection, reliability and stuff. But hopefully in future, because nowadays people are more used to technology, and if they can manage their own technology, the nurses don't have to drive 200 kilometers just to set up the system for them.
Yeah.
And that might be useful too. And maybe with like drones, delivery of equipments and all that stuff, maybe one day the delivery of medication from the local pharmacy can be run by unmanned drones. I don't know, maybe I'm thinking a bit too far, but I think technology is the way to overcome all these problems. And even monitoring, like you have your app now, you can monitor your heart rate, you can have a basic ECG done from your iWatch and stuff like that. So if you can, with the advancement of technology, that might be able to help a doctor sitting here in Adelaide make a better diagnosis or plan based on what the patient can provide. So I think technology, to overcome all these challenges, we have to wait for technology to advance.
Well, I suspect I know what you're going to say when I suggest this, and I suspect people would say in some ways, and one of your advertising points for working in the country is that you probably get as much out of it as you get for putting into it.
You do. I think it makes you a better doctor and a better person because you are able to relate to the actual situation over there. Because we're all doctors by default, you do have a passion to help out. No one says, I hate helping people, but I want to be a doctor. I don't think that happens. So by default, most of us would be quite altruistic, and we do want to help the community, help the patient, help the people out. So I think for a young medical student or a young doctor, that would be quite useful because remember, you are there and you are able to make a difference, make an impact, and at the same time, you're able to hone your own skills, especially when you're just starting out and with the right supervision, with the right training, you're able to hone your own skills and improve on yourself and also help the community. And at the same time, being part of a community that you might not have the experience being part of in Adelaide.
Yeah. Well, it probably brings us on to my last topic I want to talk about, which is the enjoyment of helping other people is also a similar enjoyment of cooking for other people too, and your hobby of running a restaurant. Not only the one in Tumby Bay from your property, but also one locally in Adelaide. So you went the next step. I don't know where you get all the time to do all this, but it's amazing. But you've gone the next step and actually now running your own restaurant and a chef for it as well.
Well, one of my motto in life is you can sleep when you're dead. But I mean, it's all an experience. I think life is all about an experience, and that's the same with anyone wanting to have a bit of a country experience. It depends on what you see life. So there's always two views. So you can go to the country and think, I have no choice as part of the curriculum. I just have to do it for 3 months or do it for 3 weeks, as part of my rural week, and then that's it. Or you can go in and say that this is an experience that I've never had the chance to, and I really want to see whether you might not like it. It might not be you. You might be, a big city person and hate the idea that you can't go to the cafe, for example, or there's no cinema, but it's still an experience. So you don't know until you've tried it, because you might love it.
Yeah.
So it's the same with like cooking, and I took the leap, obviously, and and opened a restaurant, even though it's still sort of my passion project, not really making any money. I'm actually losing a lot, but it's still a passion project, and it's a good outlet for myself, because we can't just fully, I don't know, maybe it's different from a surgical point of view, because as a surgeon, you are just immersed in it. And that's why I thought, oh, no, I'm not cut out to do that. But I think it's a good outlet. Everyone...
I think you need outlets. Everyone does.
Yeah, everyone needs an outlet. You can't just, just immerse in one thing. You need an outlet, in a passion, a hobby. Otherwise, you will feel you just can't go on.
Yeah. So, and tell us a bit about the restaurant.
So the restaurant is Katong House. It's on 255 Kensington Road, and it sells Singaporean food. So Katong is the suburb that I grew up in Singapore, and it has the best food, the laksa, everything. Local food from Singapore. It's a bit different. It's not Chinese. It's not really any distinct. It's an amalgamation. It's a mix. It's a mix of different cultures, like Malay, Indian, and Chinese cooking, and with our own local influence. So things like laksa, mee rebus, nasi lemak, chicken rice. Yeah, so it's different. The challenge is actually not cooking. The challenge is coming up with the process of maintaining the standard when I'm not there. And to actually come up with the process of doing. So I make all the sauces. Everything in the restaurant is made by us. So I make the base, and then everything is commercially sealed and vacuum packed and then stored. And the staff will then make the dish according to my instructions. So everything is scientifically measured out to the volume of fluid, how long you put it in the cooker, and so the taste is actually maintained. So that was the challenge. Cooking wasn't the challenge, but the challenge was to come up with a process that could maintain the quality of it when I'm not there.
Brilliant.
Yeah. So that took a couple of years.
Well, I look forward to trying it out. I haven't been there myself yet, but it's one of those things on my bucket list.
Let me know. You're most welcome to come and try it. I'll cook for you personally.
Sounds brilliant. Well, Han, it's been fantastic having you on Aussie Med Ed. Is there anything else you'd like to add to that for the listener at all?
The other thing that I would like to mention is the country people, the rural people, actually respect their doctors a lot. And I certainly have patients who would like to discuss their condition before they take the city specialists. That's what they call them, the city specialists, like their views. And I mean, I've only been there for 6 years, but like people like, Dennis Eaton and Graham Fleming, who have been there for 40 years, they know the generation, they know the problem. There's this continuity of care that is sometimes non-existent in city centers, because they know the same family for like 40 years. And and I still remember I had it was quite funny, because I had this patient that I followed through antenatal care, and then gave birth in Port Lincoln, came back, and then I look after the baby. And I just mentioned off the cuff, I told Graham, I'm like, I can't imagine, I know this baby since she was a fetus. And Graham just said, well, I know fetuses who had their own fetuses. So that continuity of care is so important. Like, they know the family history, and everything is just in there, in their knowledge bank. So they really think highly of their doctors, and like I said, Graham Fleming and Dennis Eaton can, in their eyes, can do no wrong. And you just have to deal with everything that comes through the door, even though you are least expecting it. There was I still remember one of my friends, who was actually a builder from Tumby, and he's now relocated to Adelaide. Simon Hebel. He once came back and had dinner with my friends who were like, cardiologists and other specialists. And out of the blue, he just popped a question. He was like, why are none of you rural GPs? And what he said really surprised me, because I never understood, or I never thought to see things that way. He actually said that, look, if something happened to me, Han had to, dig out stuff from my eyes, or he had to take care of this hammer on my head. He have to do everything from a heart attack to this and that. Are none of you able to do any of that? And I was taken aback, because in our training, a specialist is like, you must be really smart, lots of intensive. But actually, then I realized, to the rural people, the country people, they really respect their doctors, because they are part of the community, like you said.
So they're the ones up on the pedestal.
Yeah. And it's really quite an interesting experience. And I never expected Simon to say that. Yeah. But that was one of the things that really threw me off.
That's brilliant. Brilliant.
I say I've only been there for 6 years, but country doctors like Graham and Dennis and Quinton, Ralph, who's a surgeon, and Dr. McClay, they are the real heroes. They have been around forever, and they are the real heroes in the country, not me.
That's brilliant. That's absolutely brilliant. Yeah. Well, Han, it's been fantastic having you on Aussie Med Ed and hearing all about this.
Thank you.
It's been really, really enlightening. I'll really take my hat off to you, and hopefully catch up with some sleep on the weekend at some stage. But
you can sleep when you're dead.
Well, thank you very much.
No, thanks, Gavin. Thanks for having me.
Thank you very much for coming on Aussie Med.
Thank you for having me.
I'd like to remind you that all the information presented today is one opinion, and there are numerous ways of treating all medical conditions. This is general advice and may vary depending upon the region in which you are practicing or being treated. The information may not be appropriate for your situation or health condition. You should always seek the advice from your health professionals in the area in which you live. Thanks again for listening to the podcast, and please subscribe to the podcast for the next episode. Until then, please stay safe.